for giving us this opportunity. And also after a series of mesmerizing session, I would say it has been a great honor to be here. And now I'll be with a short presentation on high-risk obstetrics. So the topic of my topic is pregnancy in von Willibrand disease. It's a case report. Von Willibrand disease is the most common hereditary bleeding disorder. Although it affects male and female with equal frequency, women are more likely to manifest it clinically because of the bleeding challenges that are associated with menstruation and childbirth. Unlike postpartum hemorrhage in the general population, PPH may be delayed type in women with von Willibrand disease, and it accounts for nearly 6%. Now, when should a gynecologist suspect a bleeding disorder and pursue a diagnosis? An underlying bleeding disorder should be considered if any of the following indicators are present. As well pointed by Dr. Kameshwari, we have these 3 points: menorrhagia since menarche, family history of bleeding disorders, and also personal history, at least 1 or 2, which is like bruising, petechial, skin lesions, or excessive bleeding after minor trauma, or excessive bleeding after a dental work. Now coming to the case report, a 30-year-old, gravida 3, para 1, living 1, abortion 1, referred at 37 weeks and 7 days to our institution as a case of von Willibrand disease type 3 for safe confinement on 5th of September. She was diagnosed to have von Willibrand disease type 3. On evaluating with coagulation profile and von Willibrand assay during the antenatal checkup at 28 weeks, this was done because the history of PPH during the previous pregnancy delivery was informed at that point of time. This is the lab parameters at 28 weeks. She had prolonged APTT. Factor 8 was 1.75, which was way less than the normal range. And von Willibrand factor antigen was also very less. It was less than 1, and the normal range is around 6 to 200. Now the history, coming to the menstrual history, which is gynecologist, is very important. She had given a history of heavy menstrual bleeding since 12 to 13 years of since the age of menarche. That lasted for around 12 to 13 days, up till the age of 21 years. The past obstetric history, she had 1 spontaneous miscarriage at 3 months of amenorrhea 6 years back, which went uneventful. Now she had a previous vaginal delivery with primary postpartum hemorrhage, for which a blood transfusion, 7 pint PRBC, 5 pint FFP, and 5 pint platelet was given 5 years back. She also had a family history, a significant one. Her sister expired at 7 years of age due to intracranial hemorrhage due to fall. On admission, her vitals were stable. Obstetric examination was within normal limits, and she was not in labor. This was the lab parameters on admission. She had prolonged APTT values. Now we had a cross consultation done with the hematologist, and according to their advice, we had arranged for injection immunate. Immunate is 250 international units of factor 8 and 190 international units of von Willibrand factor and astocertin cofactor. Blood and blood products were also arranged. A definite protocol involving injection immunate and injection tranexamic acid was planned. The protocol for tranexamic acid was as follows. On the day 1, that is when she was about to deliver, at the time of crowning, we gave 1 gram IV, and thereafter 2 more doses, 8 hours apart. On day 2 also we'll give it IV. From day 2 to day 5, 1 gram, it's given orally, 8 hours apart. From day 6 to day 15, we give 500 milligram, 3 doses orally, 8 hours apart. Now the next drug we used was injection immunate. Immunate was also started on day 1, which is at crowning, 4,000 international units were given. And on the same day, 10 hours apart, we gave 3,500 international units. Thereafter, over the next 6 days, we had tapering doses, 2 doses each day. And the last day, we gave her 500 international units, 12 hours apart. She went into spontaneous labor at 39 weeks gestation, delivered vaginally with first-degree perineal tear, and gave birth to a female baby of 3.4 kg. Injection immunate and injection tranexamic acid was given as per the protocol mentioned earlier. We also concentrated on the active management of 3rd stage of labor. Injection methogen was given prophylactically, and also vaginal packing was done. In the postnatal period, the subsequent doses of immunate and tranexamic acid was given according to the protocol. Vaginal pack was removed after 12 hours and bleeding PV was within normal limits. Postnatal period was otherwise stable. It was uneventful and discharged on day 7. 6 weeks postnatal checkup, mother and baby doing well. Now the discussion, von Willibrand factor is a multimeric protein with its role in primary hemostasis and secondary hemostasis. There are 3 types mainly. The type 1 and 3 are the quantitative type and 2 is the qualitative type. Although von Willibrand factor and factor 8 levels rise during pregnancy and delivery, to support a prothrombotic state, there was a consensus that the levels may still not rise to the same levels that are observed in a normal pregnancy. Thus, the risk of PPH is likely increased. The von Willibrand concentrate can be used, as in this case, to raise the levels at the time of delivery. Tranexamic acid can also be given, and desmopressin may be used, but with a lot of caution. The monitoring should be continued even after birth, especially as long as 1 month after delivery. Now, how can PPH be prevented in women with bleeding disorders? A consultation with a hematologist at the 3rd trimester to ensure adequate hemostatic condition for delivery. A specialized tertiary care center is required if there is a coagulation factor abnormality at the 3rd trimester, especially when the levels are below 15 international units. Epidural analgesics or anesthesia, if considered, it should be done under appropriate hemostatic cover. An experienced clinical team must be available during pregnancy and at delivery. The clinical team must involve a hematologist, an obstetrician, an anesthetist, a nurse, a lab technician, blood bank on site 24/7, active management of 3rd stage of labor. Now, to conclude, an awareness of diagnosis and management of bleeding disorders like von Willibrand disease is a challenge, but an important asset for obstetricians and gynecologists. Through this case report, we wish to emphasize the importance of prompt diagnosis, initiation of prepartum and intrapartum von Willibrand or clotting factor replacement therapy, vigilant postpartum monitoring of blood loss and systemic follow-up in all cases of von Willibrand disease, as these measures will help in optimal recovery and prevent maternal and perinatal mortality and morbidity. Thank you.
Thank you, Dr. Chitra.